Extending treatment duration in patients with DME whose disease is responsive to steroid therapy could be instrumental in ensuring that visual disruption is kept at a minimum.
How might the 3-year results from the PALADIN study guide treatment in the near future?
I'm Scott Kraswanis here with Greg Notstein, and this is New Retina Radio's coverage of the 2021 AAO annual meeting.
Dr. Michael Singer reviewed data from a Phase 4 3-year real-world study of patients whose DME was managed with Iluvien.
And we sat down with Dr. Paul Chan, who summarized updates to ROP therapy as outlined in the 3rd edition of the International Classification of Retinopathy of Prematurity. What are the updates and what spurred the ICROP to make them? Stick with us to learn all about it.
Real-world data often don't align perfectly with clinical trial data for obvious reasons. Whenever we can get our hands on real-world data, we want to review it, dissect it, and try to understand it.
One late-breaking paper at this year's AAO meeting concerned data from the Phase 4 PALADIN study, which examined the 0.19 milligram fluocinolone acetonide implant, or Iluvien, in patients with DME over a 3-year time period. That study was presented by Dr. Michael Singer, who is joining us today.
Dr. Singer is with Medical Center Ophthalmology Associates in San Antonio and is a clinical professor of ophthalmology at the University of Texas Health Science Center, also in San Antonio. Dr. Singer, welcome back to New Retina Radio.
Thank you so much for having me. I'm so excited to be here.
There are so many options when it comes to the endpoints of a Phase 4 study. Which particular endpoints did you and your team look for?
We wanted to know the incidence of intraocular pressure lowering procedure among patients who had been treated with the fluocinolone implant for the treatment of diabetic macular edema. Recall that in terms of being treated in real life, they had to pass a steroid challenge test before they could get the Iluvien per label. And we wanted to compare the response after implantation to response before implantation. We also examined best corrected visual acuity changes after Iluvien implantation, as well as central subfield thickness and retinal thickness amplitude improvements pre and post Iluvien implantation, as well as any non-IOP adverse events. In terms of number of patients, we examined 202 eyes who received on-label Iluvien, then followed them for 3 years. We assessed them at baseline, day 1, day 7, month 2, month 3, and then every 3 months afterwards. And in addition, we looked at them 3 years before so we could get an understanding of what was like before they had the implant.
Did all 202 eyes complete the 3-year study?
No, they didn't. Some patients dropped out before 36 months, and we look at the reasons for dropout. There were the obvious ones where you had consent withdrawal or lost to follow-up, but the interesting thing, a significant number of them were excluded because of the fact that the fellow eye actually received treatment. So when patients had both eyes that received treatment, when the first eye was done, the second one was automatically stopped. So as a result, 30% of the eyes that were considered, quote, non-finishing treatment actually had the fellow eye finish treatment, but they were not considered in the final group. When you looked at the final group, 94 eyes had completed 36-month treatment per study design. It should be noted that when we look at the two groups, all the eyes versus the 36 months, most of the demographics remain similar. It is interesting that about a third of the patients had 20/40 or better vision. A third of the patients had dry retina. So this was a well-treated group of population. In terms of the vast majority, different from FAME, had pseudophakia. So essentially, you had about 86% of all the 36 months were pseudophakic in this group versus 88%. So these group of patients, a lot of them had cataract surgery already performed.
Tell us about some of the efficacy findings among those who completed the study.
So it's interesting to note that before they received the Iluvien, over the 3-year period, about 73% of patients needed 3 treatments a year, and they actually lost 8 letters as mean visual loss. After they received the Iluvien implant, they actually gained 3.7 letters, with 65% needing 0 to 2 treatments a year, and only 11% of patients needed more than 5 treatments. So the interesting thing is the treatment burden went from 3.7 treatments to 2 treatments, and yet the vision got better, and 25% of patients were actually treatment-free at 3 years.
Did the anatomic data match the efficacy data?
Actually, the anatomic data was probably even better. The anatomic data showed central subfield thickness significantly reduced at every single time point starting as early as day 7.
Safety data, particularly IOP data, are important in a study like this. What did you find?
We found that basically by doing the steroid challenge, the mean IOP remained stable throughout the 3-year trial. In terms of IOPs, when we look at buckets, IOP over 25 was about 24% of patients, over 30 was about 11%, trabeculoplasty was about 2%, and only 3% of patients needed IOP lowering surgery. And what's interesting is that 6 cases, half of which were actually due to neovascular glaucoma and not due to steroid-induced ocular hypertension. And about 20% of people needed IOP lowering medications. This is about 50% of the rate of the FAME trial, and it actually reinforces the concept of a steroid challenge is a good way to decrease the incidence of IOP-related complications.
Are there any studies on the horizon that we need to keep an eye out for?
So it's interesting. This great results was in a very well-treated group of patients. So these patients had previously been treated. We talked about the demographics. So the question that comes on everybody's mind is, what happens if we get treatment-naive patients? Could we even get better results? And that was the genesis of the New Day trial. It is a head-to-head comparison of patients treated with Iluvien as first-line treatment versus aflibercept. The primary endpoint is the number of aflibercept injections, and essentially there'll be an 18-month readout. These are 300 treatment-naive patients who will be enrolled in the trial. We are very excited as this trial is actively recruiting, and we look forward to the results in the near future.
Dr. Singer, thank you so much for joining us here on New Retina Radio.
I am so honored to be asked to speak.
It's difficult to think of a disease state that the international retina community has rallied around more than retinopathy of prematurity. Indeed, it's hard to even conceptualize what ROP treatment would look like if not for this international collaborative structure.
At the 2021 AAO annual meeting, Dr. Paul Chan outlined updates about ROP classification as articulated in the International Classification of ROP 3rd edition. He's here today to tell us more about those updates.
Dr. Chan is the chair of the Department of Ophthalmology and Visual Sciences at the Illinois Eye and Ear Infirmary, where he is also the John H. Panton Professor of Ophthalmology and the Director of Pediatric Retina and ROP Service. Dr. Chan, welcome to the show.
Thanks, Scott. Thanks, Greg. Great to be here.
Can you familiarize our audience with the International Classification of ROP?
Sure. So ICROP, or the International Classification of ROP, it's basically the language that we use to classify retinopathy of prematurity. And just to give you a little bit of history around it, the first iteration really came out in 1984. So if you think about it, it's almost 40 years ago. And then it went through, the classification of zone, stage, plus disease. And then in 1987, gave us this definition around retinal detachments. And then in 2005, so almost 16 years ago, gave us definitions like aggressive posterior, ROP, and pre-plus disease. So you can imagine that 16 years have gone by since we've had an update. One of the things that we think about is, okay, well, why, right? So why is this happening now? And we started to convene the group back in 2019 through the support of the Knights Templar Eye Foundation and the International Pediatric Ophthalmology Business Council, or IPOS. And we can go through this a little bit more detail if you wish.
Yeah, tell us about some of the updates that occurred since the most recent ICROP update that would require a new update.
Yeah, so a lot of this was driven, and if you just think about what's happened in the past 10 to 15 years, I mean, we've had the advent of anti-VEGF treatment, with Beat ROP and Rainbow, Butterfly, Firefly, all these different studies coming out. And we've learned a lot about managing children with anti-VEGF of different types. And in addition, we have so much more imaging at our disposal, right? So when you look back, at the original images. They're done with sort of older cameras, different field of view. But now, imaging is at our fingertips, and I think that that's also changed the way that we do things, especially when we think about fluorescein angiograms and OCT angiography. All these tools that we really didn't have at our disposal before. So I think these are sort of the drivers of what we're learning about the disease now, which then says, okay, well, we have to rethink this classification system. When you look at I know we're going to talk about this a little bit, but just the main things that we think through, this was truly international group that got together to the classification system. So the main things that we sort of tackled were AP-ROP and the discussion on AROP, reactivation, regression, defining this posterior zone 2 or also a notch. And I think very importantly, a discussion around this spectrum of plus disease, adding to this sort of discussion on plus and pre-plus.
Let's chat about the most recent convention of the ICROP. Tell me about the makeup of the panel that makes decisions.
Yeah, so this was a terrific group. I mean, I can't say any more about how wonderful this group was. And it started really as a conversation with a number of people, specifically Mike Chang, Graham Quinn, Alistair Fielder, and some others who are really experts in the field, and thinking through, well, we want this to be internationally represented, right? And we want this to have a good diversity of people. So, Mike Chen was the chair of the committee, who's now, everybody knows that Mike is now director of the NEI. There were 34 ophthalmologists from 6 continents, 20 retina surgeons, 14 pediatric ophthalmologists, 22 men and 12 women. And, I think that this was important because it wasn't just a heavy Western-driven or US-centric group. You got people from all over the world, which I think was relevant, especially as we started talking about things like aggressive ROP.
That's quite a diverse panel. And what were some of the findings of that group? And why don't we start with aggressive ROP, which you mentioned a little earlier?
Right, and I think that this was one of those discussions that, and this is why it's so much fun. We've had a lot of discussions around aggressive ROP and should we add this or shift the aggressive posterior ROP definition. And I think one of the important issues around this is that, well, we want to have international representation and create definitions that relate to not just the things that we see in the United States. So aggressive posterior ROP, which I think we all recognize happens in the smallest and youngest babies when they're born, you get different disease in resource limited settings. We've all seen different disease in heavier, older babies who can develop aggressive disease, and it may not be so posterior, right? So aggressive ROP really focuses on the tempo of the disease and the vascular features that we see in the disease, as opposed to focusing on the posterior nature of AP-ROP.
Let's turn to ROP reactivation. What are some updates that are worth noting?
Yeah, I think that this is one of the critical pieces of this classification. And a lot of this, again, as I mentioned, revolves around, what is it now, almost 16 years of using anti-VEGF. So we're seeing more reactivation or a different type of reactivation potentially. But when you look at the literature over the past decade about investigators defining reactivation post anti-VEGF treatment, the definition of it is variable. There's some heterogeneity depending on who you talk to. So developing some consensus around what reactivation is, I think, is critically important, especially going forward. If you think about it, why create this nomenclature? Why create the language? Because we all have to agree on the language in order to proceed with clinical trials and to get information that's going to be valuable for clinical care. So reactivation, I think, was a critical piece of that. And I think very importantly, the group created some language around this. For example, recurrent vascular dilation is important, or the development of new vessels, right? So you can refer to the article to get this. And I think this will be important going forward when we think about our clinical trials.
I understand there's an update to the definition of stage 5 disease.
Yeah, and again, I think that this was another fun discussion. So the question is, well, we have stage 4 and stage 4A and 4B describing retinal detachment, right? And that's a partial retinal detachment, either involving the macula or not. But then stage 5, and historically the surgical outcomes for stage 5, anywhere you go, have not been great, right? But then there was the suggestion to say subclassify or further classify stage 5 into 5A, B, and C. Why is this potentially important? Again, I think that if you think about surgical trials or surgical outcomes, this may help guide us as to say, okay, well, maybe this child is a better candidate or not. But again, this is language and definitions. It's not giving us prognosis or telling us what to do with the condition, but this language will guide us forward as we start to look at trials and studies to look at outcomes.
Before we end our conversation today, what changes to the guidance related to plus disease does the audience need to know about?
Yeah, I think that this was really one, again, I think reactivation and plus disease are probably two of the more critical pieces around this. And it's really the recognition that plus disease is a spectrum of disease, right? The vascular features that we see. And the work that I've been fortunate enough to be part of with Mike Chang and Pete Campbell and the group with IROP, we've used these AI algorithms, so IROP DL, to create what we call a vascular severity score, and looking at the different features of the posterior pole changes as they are mild versus worse, right? So what we've recognized, I think, as a community is that plus disease, as opposed to just being binary of yes, no, you can get different vascular changes and different severity that can be plus disease in general, right? So I think that, again, more to come, more discussion. One of the important things that came out of this is also it's the posterior pole vessels, right? And you also don't need to have the anterior chamber, for example, vascular engorgement of the iris and so forth as part of the definition of plus disease. But still, again, I urge this in the discussion, these are definitions, right? And these are classifications, not telling us what prognostically is going to happen or what to do.
All good to note. Dr. Chan, thanks for coming on the program.
Thanks so much, Scott. Thank you, Greg. Really wonderful being here and having this discussion.
That's a wrap for this episode of New Retina Radio's coverage of the AAO 2021 annual meeting.
Go back in your podcast feed and listen to past episodes covering the meeting, and don't forget to subscribe to New Retina Radio on your podcast app of choice.